Committee West Zone. Chairman Mission Pink Health IME Raipur, Executive Member of CG ISAR and also Chhattisgarh SFM. The past offices held by Dr. Asha Jain are, she has been the President of Raipur OB-GYN Society. She has also been the Vice President of IME Chhattisgarh, President of Rotary Club of Raipur North. So ma'am has received training in colposcopy and she's also a certified instructor in FCCS OB course. She has received IOTA certification, Certificate of Competence from Gynec Academy. Her fields of interest are saving the uterus, fetal medicine, OB-GYN ultrasound, critical care, preventive oncology, and colposcopy. Ma'am, I please request you to please take the program forward.
Thank you, Sujya, for that kind introduction.
My
and
pleasure.
to all the guests who have listened to it. Before we officially start the program, I would like to invoke the blessings of the divine. So would you please share the next slide, please?
Vakratunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakareshu Sarvada. Asito ma sadgamaya tamso ma jyotirgamaya mrityumamritangamaya. Om Shanti Shanti
So may the searchlight today be directed on secondary amenorrhea in association with Bhimavaram, Malanadu, Mandya, Mangalore, Malegaon, Mau, Mehsana, Miraj, and Hubli Obstetric Gynec Societies. I would like to welcome our guests of honor, Dr. Sudhir Shah sir, Dr. Reena Srivastav ma'am, and Dr. Kanchan Sharma to this webinar. I also welcome Dr. Sujay Sri Sangeeta as our convener. I'm very grateful to have Dr. Lakshmi Sheshadri ma'am and Dr. Shobna Mohandas ma'am as our respected speakers, and Dr. Sumant Kulkarni, Dr. Mukund Patel, Dr. Chandrasekhar Nayak, Dr. Aruna Kamath, Dr. Annie Soman, Dr. Pradeep Ganiga, and Dr. Kusum Verma as our chairpersons, and Dr. Ramesh Kumar sir, Dr. Pradeep Dorle, Dr. Annapurna, Dr. Vasanta Lakshmi, Dr. Sheila, Dr. Sahana, and Dr. Ekika Singh as our chairpersons. I welcome all the delegates, and I hope this will be a learning experience to all of you as it is to all of us as well. Now, I would like to have the CV of Dr. Sudhir Shah sir. So, Dr. Sudhir Shah sir is an MD FICOG and infertility specialist, and he is working as senior consultant at Manan Hospital, Rajkot. He is an ex-assistant professor at Baroda Medical College. He has authored 7 books on various gynec subjects, past president of Rajkot, invented SRS needle for surgery of NDVH, and has delivered Ahmedabad Gynec Society oration on NDVH. More than this, he is a very senior gynecologist who is ever ready to encourage all juniors in the field. So welcome, sir. We are very grateful to have you here and would like to hear a few words of blessings. You are muted, sir. Sudhir Shah, sir. The left corner of your screen, there is the unmute button.
Is it unmute?
Yes, sir. Done.
Done. Okay. Thank you very much. To organize webinar very regularly, and that too with the different faculties, different societies, different projects is a challenging job, and Asha and our team is doing wonderful job for the newcomers and seniors also who is doing practices. And webinar is a good way to get the people and to most of time travel and it's a very good tool, has given us a good gift of this webinar. And many sites are participating today, and I would like to inform them, request them that Dr. Asha is casting for the cost of the food drug management of FOGSI. So request all of you to nominate from your society, and in July or August, whenever election date, then please vote for her, your secretaries, colleagues to go there. So all the best. Please carry on these things. Thank you. Thank you very much.
Hello. Sujaya?
Thank you.
Yes, ma'am.
Thank you very
Ma'am,
much.
I think this
Dr.
network issue on
Kanchan
her
is
side.
having some problem. Dr. Kanchan is having some problem. Could you please call her?
Yes,
And
ma'am. I'll
thank
do
you,
that.
Sudhir Shah, sir. Thank you so much. And for those words of blessing. Now,
Thank you.
yes, next slide, please. I would like to introduce Dr. Reena Srivastava, ma'am. She is the past president, UP chapter of Obstetric Gynec Societies, past president, Gorakhpur Society, fellow ICOG. More than that, she is a very academic person. She has been felicitated by many organizations for working on humanity. But I heard her speaking on CTG, and it was such a huge topic, and she was able to really cover it so that people could understand it in a very short time. Since then, I have wanted her ma'am to come and bless our webinar as a guest. So, requesting you, Reena ma'am, be kind enough to please bless us.
Thank you, dear Asha Jain. I'm really blessed myself to be here at your platform. I have been listening to you for the last 1 year in various webinars. You are so much active, and into regarding today's topic, it is very pertinent. Speaking on having experts on secondary amenorrhea. A topic which is of day-to-day practice, and I hope after this webinar, people would be having a good insight of how to tackle these cases, not leaving any point, and so there are no litigations, and blessing the patients herself, the real management of secondary amenorrhea. So with this galaxy of experts on this board, Dr. Lakshmi Sheshadri, Dr. Shobna, Dr. Asha Jain as moderator, so many senior persons as chairpersons, and brilliant panelists over here. I hope and my best wishes for a very, very, you can say, important and knowledgeable webinar today, which is going to help all the clinicians today who are there on board. My blessings, you can say, my best wishes, my hearty wishes to you, Dr. Asha, for your future endeavor. We are looking forward for you to be there on board, for which you are looking forward. Thank you. Thank you so much for inviting me here. And really, I'm blessed to be on this board today. Thank you.
Thank you, ma'am. Thank you. Ma'am has a lecture in half an hour and she still agreed to be here. So thank you so much, ma'am.
My
Now,
pleasure.
may I have Dr. Kanchan, ma'am? So Dr. Kanchan Sharma is the chairperson of NCD Committee FOGSI. She is director and chief consultant, Akash IVF Center at Kanpur. She was the secretary of Kanpur Society last year, President Ayacharya Kanpur, and ART specialist, laparoscopist, colposcopist. She's done many trainings, has many awards, but more than anything, she has been kind enough to accept this invitation at one go. She was with us last year in Happy Learning, and I welcome you today, ma'am, to this platform to say a few words. Kanchan, ma'am.
Thank you, Dr. Asha Jain.
Would you
I'm
please stop
really
sharing?
feeling a great honor and really humbled to share the stage with such great personalities like Dr. Sudhir Shah sir, a great academician and a great FOGSI leader from Menon Hospital, Rajkot. Dr. Reena Shrivastava ma'am, past president of UP chapter, well-known academician and a loving person. My sincere thanks and best wishes to Dr. Asha Jain for FOGSI committee chairperson election. We need such hard worker and the honest person in our FOGSI. Devotion with full smile and loving heart is always appreciated. Dr. Asha, I am really appreciating your this update on Secondary Amenorrhea Searchlight Series 23 with the 9 societies. There are great speakers in this, Dr. Lakshmi Sheshadre, Dr. Shobna ma'am, and panel is moderated by you on Secondary Amenorrhea. Again, heartful thanks and congratulations in advance to you for your and best wishes for your upcoming. Thank you very much. Thanks.
Thank you so much. Thank you so much, respected guests. Sudhir Shah sir, Reena ma'am, Kanchan ma'am. You are, if you have the time, you are most welcome to stay on. Otherwise, we will be starting our academic session now. Over to you, Sujya, to please introduce the chairpersons of the first talk.
Yes, ma'am. So moving on to the academic session 1, which is etiopathogenesis and diagnosis of secondary amenorrhea. We have Dr. Lakshmi Sheshadri as our speaker. Firstly, I would like to introduce the chairpersons for this session. Next slide, please. Here we have Dr. Sumant Harikulkarni with us. Sir is a consultant obstetrician and gynecologist at Swananand Nursing Home. He has been awarded the Young Talent Award Contention Device in Siliguri AICOG. He's also received training at Dr. Rajan in Kottayam. He's also received training at Vijayawada, Dr. P.G. Paul Cochin, and he has received his IUI training at Manipal Hospital. He's an ex-assistant professor at BMMC, Solapur GMC, Miraj. So it's a pleasure to have you with us today. Next slide, please. We have Dr. Mukund B. Patel, sir, who is the president of Mehsana OB-GYN Society. Sir is a laparoscopic surgeon and vaginal surgeon. He's also a sonologist. He's an assistant professor of OB-GYN at GMERS Medical College, Patan. He has completed his graduation and post-graduation from BJ Medical College, Civil Hospital, Ahmedabad. He started his private practice in the year 1993. So Sir has been the organizing secretary of various state conferences in Gujarat. He has also been the vice president of GSB IMA Gujarat. He has presented papers in numerous journals and also in various conferences. So welcome to today's session. We have Dr. Chandrasekhar Naik with us. Sir is a consultant OB-GYN at St. Joseph's Hospital, Dharmagiri. He is the president of Malanadu OB-GYN Society. So welcome to today's session.
Thank you.
Lastly, we have Dr. Aruna Kamath with us. Madam is the immediate past president of Mangalore OB-GYN Society. Ma'am, it's a pleasure to have you with us. Sorry. Ma'am, I would request one of the chairpersons to please introduce the speaker, Dr. Lakshmi Sheshadri, ma'am.
Can I, Dr. Shankh here?
Please,
Can I?
Yeah, please, sir, go ahead. Sir.
Welcome, Dr. Lakshmi Sheshadri, madam. She is professor and a former HOD of OBGYN department, CMC Vellore, and senior consultant in OBGYN department, Tirumalai, Mission Hospital, Ranipet, Vellore, and she has more than 90 in index journals presentation, chapters in textbooks of authored textbooks, Essentials of Gynecology and Essentials in Obstetrics, and revised it many times. Several oration awards are with her in various conferences. Area of interest are gynec oncology and menopausal medicine. And she has done various community work, screening for cervical cancer with the VIA, and screening for screening and management of NCDs in rural populations. She will be speaking today etiopathogenesis and diagnosis of secondary amenorrhea. We are delighted to hear from Dr. Lakshmi Seshadri, madam. Over to you, madam. Hello. Hello.
Madam, are you with us, Dr. Lakshmi Seshadri? Ma'am, please unmute yourself.
Yes,
ma'am.
yes,
Dr.
I've done that. I've done that. Thank you, Dr. Chandrasekhar Naik, for that introduction. I'd like to thank the organizers of the meeting, especially Dr. Asha Jain and the other members of this group, Dr. Sujayashri, for giving me this opportunity. Many of you I'm meeting for the first time, and many, of course, I have met and certainly heard of in the past. And I think I really am honored to be part of this group. I am now going to share my screen and start the talk without much ado. All right, okay, fine. The topic that I have been given is etiopathogenesis and diagnosis of secondary amenorrhea. The management will be handled by Dr. Shobana later. I don't think that it is a very, very relevant topic because we are seeing more and more adolescents and even young adults coming with secondary amenorrhea to our outpatient clinic, largely because of the lifestyle changes, the stress that people go through, the weight loss, weight gain, the dietary changes, modifications, and all of this have an impact on the hypothalamic pituitary ovarian axis and affect the hormones which are involved in menstrual cycle or menstruation. And secondary amenorrhea has become quite a common problem. Before we proceed, I would answer a basic question, which is how do we define secondary amenorrhea? It is the absence of menstruation for more than 3 months in a woman with previous spontaneous regular cycles. It's a standard definition. And it is amenorrhea of more than 6 months in women with previous irregular cycles. But evaluation is also recommended in the following situations, like in women with less than 9 cycles in a year, an intermenstrual interval of more than 45 days in girls who are older than 2 years after menarche. 2 years after menarche is important because in the initial 2 years after menarche, the cycles can be quite irregular. Whereas after 2 years, 2 to 3 years, it has to kind of regularize. And if the interval is more than 45, they need to be evaluated, even though they don't come under the definition of secondary amenorrhea. We might now ask the question, is it necessary to evaluate women with secondary amenorrhea? Is it necessary to have a diagnosis? Can we not just treat with hormones? Okay, if you give them progesterone, they may bleed. You give them a combination pill, they may bleed, and everybody is happy. But the answer is that there are several other problems that are associated with secondary amenorrhea. Amenorrhea is only one of the manifestations, and the other problems have also to be dealt with. The psychological problems, anxiety with altered self-image, loss of self-esteem, possible decrease in fertility, symptoms of hypoestrogenism, which may be short-term manifestations of an early menopause. It can be long-term problems like osteoporosis and coronary heart disease. Symptoms of hyperestrogenism, like endometrial symptoms and effects of hyperestrogenism, like an endometrial hyperplasia, an increase in the risk of endometrial malignancy, hyperinsulinemia, insulin resistance, the metabolic syndrome thereof, and hirsutism and its effects. So, considering all these problems are associated with secondary amenorrhea, you need to certainly evaluate. And before we go on to that, we look at why this happens. The basic pathology is an interruption of the hypothalamic pituitary ovarian axis at any level. I think that everybody, even the undergraduates, understand. You could also have a situation of end organ unresponsiveness. There can be other endocrine disorders which can lead to secondary amenorrhea, and general poor health status is usually associated with amenorrhea as well. Now, pictorially represented, you can see that this hypothalamic pituitary ovarian axis, you have the hypothalamus at which you can have various causes. You have pituitary where you can have hyperprolactinemia and various causes. You have the ovary where you have PCOS or POI, and the uterus, that is the end organ, where you can have a problem.
पानी
You
ऐसे
know,
सब कुछ है, ये तो हमने निकाल के रखा, किसी को भेजो पानी
you can
भेजो।
also, I think somebody
Please
hasn't
request
muted.
everyone to mute their.
Yeah. There can also be problems with the, at the level of the
Pranjal?
thyroid or adrenal. All these can give rise to amenorrhea. So, as I said, the problem may be at the hypothalamus, pituitary, ovary, endocrinopathies, especially adrenal and hypothyroidism, systemic diseases. So, what are the problems at the hypothalamus and how do these give rise to amenorrhea? Functional hypothalamic amenorrhea is the most common at the level of the hypothalamus. We need to understand that, and especially in adolescents, the stress that they go through preparing for their 12th exam, the NEET exams, the coaching, the stress, pressure on them. There can be a lot of weight loss associated either because of athletic or anorexia nervosa. It can be genetic. And of course, in women, in these girls who are preparing for all these, there can be a lot of weight gain. Obesity is very, very common in the adolescent these days. And this is associated with the polycystic ovarian syndrome. Now, hypothalamic causes account for 30% of all cases and is the second most common cause of secondary amenorrhea. The functional hypothalamic amenorrhea causes a decrease in the GnRH secretion. It can be a decrease in the pulsatile secretion or absence of mid-cycle surge of LH. This is what the GnRH decrease causes. It, of course, is associated with anovulation and serum FSH level is low or normal. And therefore, the serum estrogen also would be low. Common in young girls, especially because of stress, inappropriate diet, and lack of or excessive exercise. The weight loss causes increase in the release of all these hormones, catechol estrogens. It causes a relief, catechol estrogens, ghrelin, and endogenous opioids, alteration in kisspeptin, and decrease in the leptin. And all these act by reducing GnRH secretion. Now, other hypothalamic causes are not so common, and they also act by decreasing the levels of GnRH, therefore decreasing gonadotropins and estrogen. The most common ones are tumors, encephalitis, chronic illness, etc. The features of hypothalamic amenorrhea that we need to remember are that most often due to change in weight or stress, lack of LH pulsatility and mid-cycle surge, there's no ovulation, estrogen levels are low, and there is no withdrawal bleeding with progesterone. When it comes to evaluation, these become important. Pituitary causes start with hyperprolactinemia. There are several, but hyperprolactinemia and pituitary necrosis or Sheehan are the two common ones. There can also be pituitary adenomas, which either secrete prolactin or other pituitary adenomas, and there are other less common diseases. What we need to remember is that pituitary tumors, contrary to what we imagine, always result in a reduction in the GnRH secretion and not an increase in the the gonadotropin secretion and not an increase in gonadotropin secretion. So pituitary conditions are associated with low gonadotropin levels. Pituitary adenomas, lactotrope adenoma is most common. And the other adenomas do not cause menstrual abnormalities except a gonadotropin adenoma, which may be associated with a decrease in the secretion, and stop compression can occur with any one of this. And this again causes a reduction. Now, hyperprolactinemia, there can be many causes, but we are worried about the pathological and pharmacological ones, usually associated with a reduction in GnRH and therefore gonadotropin levels. History of medications is very important. The hypothyroidism must be excluded. And remember, renal disease can cause delayed clearance of prolactin. Pituitary necrosis, which is the second most common at the problem at the pituitary level. This occurs following PPH, and there are other signs which are very well known. TSH, prolactin, FSH, and LH are all low. Therefore, the features of pituitary amenorrhea that we need to remember are that they are most often due to hyperprolactinemia or Sheehan. gonadotropin levels are low, estrogen levels are low, serum prolactin helps to differentiate between the two conditions, and there is no withdrawal bleeding with progesterone. Moving on to ovarian disorders, this is the most common cause of secondary amenorrhea. Alteration in the hypothalamic being the second most common. Alteration in estrogen and or progesterone secretion occurs whenever the ovary is affected. You have polycystic ovarian syndrome and primary ovarian insufficiency are the two common causes. If I get into the description of polycystic ovarian syndrome, it's going to take all day. So I will just say we all know the definition. And in the adolescents, the definition may be slightly different from what is in the adults. Now, if you just broadly look at the pathophysiology, obesity leads to hormonal imbalance and in peripheral production of estrogen, insulin resistance, hyperlipidemia, giving rise to hyperandrogenism, functional ovarian hyperandrogenism, and alteration in the pituitary LH production. All these lead to anovulation, various manifestations, and amenorrhea in polycystic ovarian syndrome. The next cause at the ovarian level is primary ovarian insufficiency, which is usually ovarian failure with high FSH levels occurring under 40 years of age. There are two categories. The first one associated with accelerated follicular depletion, which is usually associated with any chromosomal abnormality, even Turner mosaic or galactosemia, sometimes autoimmune. POI without follicular depletion, which we used to call resistant ovary in the past, is because of a defect in the FSH receptors in the ovary, estradiol precursor production, or aromatase, defects in aromatase function. So the features of amenorrhea are due to ovarian disorders that PCOS is the most common, diagnosis is clinical, there is withdrawal bleeding with progesterone. POI is most often autoimmune, elevated FSH, and no withdrawal bleeding with progesterone. Uterine causes, we all know, intrauterine adhesions, tuberculosis, sometimes cervical stenosis. FSH and LH are normal. No withdrawal bleeding with progesterone because the endometrium is unresponsive. Other endocrinopathies, hypothyroidism, Cushing's, we all know. NCCH, that is non-classic congenital adrenal hyperplasia, something we all have to remember because it is an important differential diagnosis for polycystic ovarian syndrome. Hirsutism is more pronounced in this condition. Sometimes virilization can be present. Remember, virilization never happens in polycystic ovarian syndrome. Serum 17-alpha hydroxyprogesterone and DHEAs are elevated in this condition, and these are the two tests that will help us differentiate between the conditions. So, to summarize the pathophysiology, the etiopathogenesis at the hypothalamic level, decrease in the GnRH, lack of pulsatility of GnRH production, acts on the pituitary, decreases FSH and LH, and increase in prolactin, and these pathologies may be already there in the pituitary. These, of course, have an effect on the ovary, and they decrease estrogen progesterone function, and you can also have follicular depletion already existing in the ovary, which is a cause by itself, and they are supposed to act on the uterus, but the uterus may be unresponsive, and there can be pathology like intrauterine adhesion and tuberculosis. So, how do we evaluate women with secondary amenorrhea? We have to start with history with an emphasis on certain points like weight gain or loss, postpartum hemorrhage and lactation, galactorrhea, history of curettage, menopausal symptoms, medications, family history, and chemo or radiation in the past. Clinical examination, you have to pay attention to height, weight, and body mass index because obesity is an extremely common cause, and so is weight loss. And no woman should leave our clinic without having a body mass index calculated. Blood pressure, signs of hyperandrogenism, signs of insulin resistance, breast examination, thyroid examination, pelvic examination are all mandatory. Now, how do we go on to further diagnostic workup? A stepwise approach works well, and I'm sure all of us follow some such algorithm. The first step would be to exclude pregnancy. Any woman who is menstruating, whether she admits to be sexually active or not, and a pregnancy should be excluded. And step 2, once it is excluded, is to estimate serum FSH, LH, prolactin, and TSH level. This should be done before progesterone challenge test is administered if we are going to administer PCT. Step 3 is to administer progesterone challenge test. This detects endogenous estrogen production, which primes the endometrium. Of course, nowadays, there are people actually have done away with the PCT in many centers and moved on to serum estradiol estimation, which of course is more expensive, but is quite sensitive and does the same thing as a progesterone challenge test, but may not be available everywhere. So if you're working in a setup where the other hormonal evaluations are available, but not estradiol, it may be easier to do a progesterone challenge test. And which is done by using any one of these progesterones and waiting for 2 weeks for bleeding to occur. Now, this algorithm is something that I find extremely useful. In a woman with secondary amenorrhea, first do a pregnancy test and exclude pregnancy. If that's negative, go on to FSH, LH, prolactin, TSH, and either do a serum estradiol along with that or progesterone challenge test. Now, you have 1, 2, 3, 4, 5 groups here. Now, if the FSH, prolactin, and TSH are all normal, and the estradiol levels are also normal, you have either PCOS or NCCH or uterine causes. Here, actually, the progesterone challenge test will help you differentiate between the two because all the levels are, hormonal levels are normal here. And once you made a diagnosis of either PCOS or NCCH, we know what to do. And when there is no withdrawal bleeding, despite normal hormonal levels, you know that the problem is probably with the uterus. If the prolactin and TSH are normal, but FSH and LH are low normal, then and estradiol is low, you think in terms of a hypothalamic amenorrhea. Whereas if all the hormones are very low, you think in terms of a pituitary failure. So the difference between this and this would be that in hypothalamic amenorrhea, FSH and LH can be low normal and prolactin TSH are normal, whereas in pituitary failure, all of them are very low. Now, if the hormone levels are high, you know it's an ovarian failure. And if the prolactin is high, you know that it is a prolactinoma. This algorithm works very well for me. Positive PCT or normal or slightly elevated estradiol, you know that indicates inadequate estrogen occurs in PCOS and non-classic congenital adrenal hyperplasia. PCOS may be differentiated from this by clinical evaluation and hormonal levels. With negative PCT or low estradiol, I already discussed, look at low normal FSH-LH or low FSH-LH. Depending on that, you do an MRI and you decide. A high serum FSH indicates POI, karyotyping and test to exclude polyglandular failure are indicated. Elevated TSH, of course, tells you that it is a hypothyroidism. Elevated serum prolactin, mild elevations up to 50 nanogram can occur in PCOS, must be clinically correlated. Levels of 30 to 50 are probably drug-induced. The levels of 50 to 100 probably can be drug-induced, sometimes idiopathic hyperprolactinemia or pituitary stalk section. High levels around 200 are indicative of a microadenoma, whereas 200 to 1000 are indicative of a macroadenoma of more than 1 centimeter. MRI is recommended when the levels are at 50 to 100 or 200 and more. If all hormonal tests are normal and PCT negative, you know that it is a uterine cause. Ultrasonography is the next step. Some people might give an estrogen-progesterone combination challenge test. So to conclude, secondary amenorrhea is a common problem. PCOS with weight gain, acanthosis, and hyperandrogenism common in adolescents and young adults. Hypothalamic disorders also common in adolescents due to stress and lifestyle changes. Sheehan's and Asherman's occur in Paris women of middle age. POI, hyperprolactinemia can occur at any age. Stepwise protocol for evaluation yields the diagnosis in most cases. Thank you very much for your attention.
Thank you so much, ma'am. Over to the chairpersons, please.
Hello.
Thank you. Thank you, Sheshadri madam.
Yes, you can go ahead.
Please go ahead, so yeah.
You can go ahead.
For
Suman,
explaining
sir.
how to. Hello.
Yeah, please go ahead, Dr. Chandrasekhar, sir, please.
Thank you, Sheshadri madam, for explaining the etiopathogenesis and how to diagnose the secondary amenorrhea in day-to-day practice, and how to distinguish depending upon the etiology that of secondary amenorrhea, pituitary, hypothalamus, and ovarian level, and managing these cases will be easier for us now onwards. Thank you, madam.
Thank you.
Thank you. Suman sir, would you like to say something?
A very good evening to you all. I think it is a dream of any person who wants to pursue a career in medical field to get the admission at CMC Vellore for UG or at least PG and super speciality. If not, at least you should get an opportunity to listen to the giant professors of CMC Vellore. And I think today we are very lucky to listen to Lakshmi Sheshadri madam for this a very routine topic of each and everybody's clinical practice. That is secondary amenorrhea. Thank you. Thank you so much, madam.
Thank you.
As we are all trained, when we are examining any patient for per abdominal examination for lump in abdomen, that we ask the patient to void the urine first, because the full bladder always confuses your diagnosis. Likewise, when a patient steps into your OPD with a case of secondary amenorrhea, I think one should rule out first the commonest cause like a pregnancy, lactation, and of course at the later age, the menopause. Lakshmi madam has really given an exhaustive list and information of how to approach these patients and how to investigate. I feel today honored to be in the galaxy of these obstetricians and gynecologists on this platform, like Dr. Sudhir Shah, Lakshmi Sheshadri ma'am from Vellore, Kanchan Sharma ma'am, and Shobhana Mohandas ma'am. And of course, the main backbone behind this webinar series, the Searchlight, none other than Dr. Asha Jain ma'am. Thank you very much, Dr. Ma'am, for giving this opportunity and a very nice informative lecture, Dr. Lakshmi madam. Thank you.
Thank you.
Thank you. Thank you, Suman sir. Thank you, Chandrasekhar sir. Over to you, Sujya.
Yeah, ma'am, finally, I would just like to add, we've seen during our PG days, we've had a lot of lectures from Dr. Lakshmi ma'am. So it's almost like I've gone back to my PG days. Ma'am, it was an amazing session. I almost felt like a postgraduate running through everything. So, and ma'am, when I actually recommended your name to Dr. Asha Jain, ma'am, I was like, we have to give this lecture to Dr. Lakshmi ma'am. Ma'am, you've done great justice to it, ma'am. And it gives me great pleasure to say this is one of the best lectures you've had on our series to date. Do you agree, ma'am? Asha, ma'am.
Yes, yes. Ma'am, I've taken your protocol screenshot and I've shared it in the group so that everybody can keep it.
Thank you. Thanks.
Thank you, ma'am. Thank you once again. So moving on to the next session. Can we have the slides?
Would you please share the CVs?
Yeah, Dr. Prajwal. Sorry, Mr. Prajwal.
He's Pranjal, Mr. Pranjal.
Pranjal, okay. Yeah. Moving forward towards the next session, it's management of secondary amenorrhea. We have Dr. Shobhana Mohandas as a speaker. I would firstly like to introduce the chairpersons of the session. Next slide, please. We have Dr. Annie Suman ma'am with us. She has done her graduation and post-graduation from Government Medical College, Thiruvananthapuram. She is a professor emeritus of OB-GYN department from Medical College, Kolancherry. She has served in the Government Health Service for the last 17 years. She has also been the past president of MOGF. She has been a speaker and chairperson in various conferences, and her areas of interest are high-risk obstetrics and laparoscopy. Welcome, ma'am, to today's session. We have Dr. Pradeep Kaniga sir with us, who is the president of Mangalore OB-GYN Society. Welcome, sir. Dr. Kusma Verma, she is the director of Ashish Nursing Home. The previous position held by her, she has been the founder member of OB-GYN Society, MAU. She is the president of the same. She is the past president of IMA MAU, ex-vice president. She has also been the chairperson of AICOG Calcutta in 2008 and also in AICOG Varanasi 2012. She's the zonal coordinator of Inner Wheel Club District. She's received awards and she also has special interest in emergency obstetric care, high-risk pregnancy and cervical cancer. Welcome, ma'am, to today's session. I request one of the chairpersons to please introduce our speaker for the second talk, Dr. Shobana Mohandas. Yeah, can we have Dr. Kusma Verma introducing the speaker,
Dr.
please?
Kusum Verma, ma'am.
Good
Dr.
evening to
Soman,
all.
ma'am.
Good
Yes,
evening.
Kusum, ma'am.
Yeah, please.
Yes. I am audible.
Yes, ma'am, you're audible. Go ahead, ma'am.
And it is my great privilege to be the part of this webinar. Here I am introducing Dr. Shobana Mohandas. She is consultant gynecologist and laparoscopic surgeon, Sun Medical Center, Thrissur. She is past president Indian Menopausal Society 22-23. She is past president of IMA Thrissur, past secretary general quiz chair and website chair IMS, founder secretary Calicut Menopausal Society 2009, organized several endoscopic workshops and CMEs. She is South Zone coordinator of FOGSI histoscopy workshop in 2011. She has presented many papers. She is free paper chairperson at AICOG 2016, past active member of FOGSI, Endocrinology and Food and Drug Committee. She is invited faculty at more than 400 various nationality, authors 2 textbooks of gynecology and contributed chapters to many textbooks. She is graduated and post-graduated from Grant Medical College, Mumbai, 1982. Over to Dr. Shobana Mohandas.
Thank you, Dr. Kusum, for reading my
It's pleasure, ma'am.
biodata so much in detail. I had told Asha to just keep it. No, anyway. Thank you, Dr. Asha, for calling me to your webinar. We had a talk in Raipur, and I think that is how we got to know each other better. Now, can I share my slide?
Please,
Can
ma'am,
you
please
put
go
up
ahead.
this-
Pranjal, would you please stop sharing and make Madam the co-host?
Thank you, Dr. Asha, for giving me this topic because I've been called only for menopause topics, and it's so refreshing to try to talk on something different, you know. So here we go. I bring you greeting. Is my slide shared?
Yes, it's shared.
Yes,
Can you
ma'am.
make it
It's
full
shared.
screen,
You
ma'am?
need to make it full screen.
Okay, I'll make it. Okay. Yeah. Okay. Now it's okay?
No, it
No,
did
ma'am,
not
just click
click,
on,
ma'am.
yeah, now it's
now
fine.
done.
Yeah. So bring you greetings from Thrissur, and I wish Dr. Asha all the best for her endeavors in FOGSI chairperson committee. All my prayers for you. Yes, there's some overlap between diagnosis and management, no? Secondary amenorrhea, first thing we have to rule out is pregnancy. And definitely you can't tell the girl, you go get your pregnancy test done because they may hit you. So you have to tell her, you go, look, if you've got a PCOD, you've got an ovarian cyst, and then you find she's pregnant. If you have a sac, you're happy. If you don't have a sac and you know, if it's just a thickened endometrium, you are again in a soap. But yes, pregnancy is the first diagnosis. And once that is ruled out, then you can give your progesterone challenge test. When Spiroff told this as the first line of investigation, tests like TSH, prolactin, FSH used to take many days to get. Therefore, in the current scenario, before progesterone challenge test, just like Lakshmi Madam said, you please get the basics like TSH, prolactin, and FSH and hemogram. But meanwhile, you can give your medroxyprogesterone acetate for 5 days, wait for bleeding. That will take a long time to come. In between, you can approach a diagnosis just with your ultrasound and your reports. Now, I cannot give the diagnosed management of all the conditions, so I will just tell you salient features of what I think is little more than what you may be doing in your practice. Diet and exercise, if you tell the patient in a PCOD, she is going to hit you, she is going to hit anybody. Nobody likes to be told to diet. And metformin is the next first-line treatment, but you have to give metformin for 3 days, 1 tablet, 3 days, 2 tablets, 3 days, 4 tablets. You can go up to 2 grams, but maximum I give is 1,500. But then you have phone calls in the middle of your consultation. Doctor, the tablet you gave me, it's making me sick and it's making me puke and, you know, my stomach is bloating. What have you done to me? So these phone calls are not uncommon. And so it's not every person who can take metformin. And so you have to give myoinositol. The myoinositol, the research dose is actually 2 grams twice daily. And then it's a new kid on the block, but there are many, many variations. They're saying you add chiroinositol in 1 in 400, 1 in 200, but there are no vis-a-vis studies between myoinositol 4 gram and myoinositol d-chiroinositol combination. Because both are food products, they don't need FDA approval, so you don't really need a lot of studies. And the medical reps, they will just tell you what to do. There are studies of d-chiroinositol, myoinositol combination versus, with metformin versus metformin alone. But really, what is the dose of myoinositol? Is the medical rep right? Is the study right that we have to choose on our own? Personally, in my practice, I do not come down from 2 grams twice daily. And I tell the patient it is costly. Your girl may be getting a vomiting sensation. If you are ready for that, let's try metformin. If you're not ready for that, if they're coming from abroad or from somewhere else, they're straight away going for myoinositol. So why am I choosing myoinositol? Yes, there are head-to-head studies on myoinositol and metformin. But the insulin resistance and the weight is affected by metformin, but not with myoinositol. The cycle length is decreased in both. There are no adverse effects with myoinositol. Therefore, the studies in 2022 at least say myoinositol is at best a second agent if metformin is not tolerated. So if your long distance patient need it, you can start it as first agent, but in the right dose. Whether the combination of d-chiroinositol and myoinositol, where myoinositol is only 500, whether that works, I could not find studies. Maybe there are studies, I did not look hard enough. So now, myoinositol, metformin is one aspect. The other aspect is my thin PCOD patients. Although there are many gliptins mentioned in the literature along with vitamin D. Vitamin D is there in most of the myoinositol sachets. One molecule which I found useful in my at least infertility thin patients with PCOD is pioglitazone, which I don't find many prescriptions. Pioglitazone in 2023, there has been found that beneficial effects can be there along with alpha lipoic acid in PCOD. In my practice also, thin PCOD is infertile patients, non-infertile patients. But let me tell you, some patients can't tolerate pioglitazone also. But most of them, they can tolerate. The thin patients can put on weight because pioglitazone is going to make you put on weight as compared to metformin, which will make you pull down. So that is my choice of managing insulin resistance. Now, there is another thing. A lot of patients will have this apnea at night because of the heavy, they are fat and everything. They can't sleep at night because the tongue falls back and they lose their sleep. So these are the patients where your melatonin can be used. Because melatonin in PCOD can modulate the secretion of FSH and LH. It can enhance insulin sensitivity. And also it has got an anti-inflammatory. Therefore, at least patients who complain of sleeplessness or in infertility patients where I've given myoinositol, metformin, all sorts of things, and it doesn't work there, I do give atorvastatin and melatonin in addition, and then even those, probiotics, they are also there in the market, which decreases anti-inflammatory effect. So you add up all this. So these are some of the new kids on the block in infertility, in secondary amenorrhea due to PCOD. Now, patients always like to have natural products, and some of the things which had studies on them are almonds, pumpkin seeds, sunflower seeds, khaskhas or poppy seeds, and sesame seeds. So they are supposed to, sesame seeds, even our patients say, when they take that, they start getting periods. So that's known even commonly. Now, licorice powder, 1/2 a spoon daily. Fenugreek is very common in South India, and your, biryani ka kadi, this thing, cinnamon, that also 1/2 a spoon. You can powder all these things and keep a little bit. You can take this methi or fenugreek. You can put 1 teaspoon in 1 glass of water overnight and boil next morning and drink. So patients like to get some natural products besides whatever medicines you give, because they are, it's feel-good factor also, and these are also research products. So these are things I wanted to give besides the normal ones. Now, hyperprolactinemia. We already had Dr. Madam talking about it. Now, bromocriptine I used to give earlier in my practice, but it is almost, there are many gonides, but cabergoline is the in thing right now, which has to be given 0.5 to 1 milligram twice weekly till prolactin levels are normal. That means how long will you give? You may take 1 month, you may take 2 months, you may take 3 months. That we have to wait and watch till the prolactin levels are normal. How long will you give? When the prolactin levels are normal, for 6 months, you have to continue the same dose. Once they are normal totally for 6 months, then maybe you can stop it. But even after stopping, after some time, if it recurs, you may have to restart again. I had a patient who had her prolactin of 200, which I missed. She had come with DUB, not amenorrhea. Mind you, she had come with DUB. And I had given a progesterone, but she ran off to another hospital and they found high prolactin levels, almost to the tune of 100 and something, nearing 200. And they immediately found a microadenoma and they said, you need operation just now. We have to operate on your pituitary. And somehow she reached back to me. I had done laparoscopy on her twice for intestinal addition. So she used to keep coming back to me. So I told her, for this amount of prolactin, you don't need to do a surgery. You just take cabergoline. And then she started taking cabergoline and her prolactin levels came down. But then after some time, she stopped it and she disappeared again. She again came back. This time again amenorrhea, but her hemoglobin was 5 grams. So can you imagine, because of the DUB, her hemoglobin went down and she's again getting amenorrhea. So I said, again, now you have not done your prolactin for 1 year. You have come to me 1 year back. So get your prolactin levels done. But meanwhile, I would like you to go to a hematologist. And then there was again no news from her. But my lab people, they call up some few months back and said, Madam, your patient's got us 200 prolactin. That means after stopping cabergoline, it has again come back. So you have to monitor your patient. And you have to tell them, please come back to me. And so even if they have come with secondary amenorrhea, in my patient, she had come with DUB, very strange, but yes, you have to monitor them when they have got very high prolactin levels. Hypothyroidism, I think generally you have to take lifelong. But I have had patients where I've given thyroid and then stopped it after delivery. And after a few years, even 10 years later, I have seen that the thyroid levels are normal. I don't know what the guidelines say, but most people do try to give it lifelong. Now, one thing is psychiatry patients, neurology patients on antidepressants, antipsychotics, haloperidol, all of them have high prolactin levels and they will come with amenorrhea and they are also fat. But if you reduce the prolactin levels, the symptoms will come back. And so you have to explain to them that, look, you're getting periods is not important. You remaining asymptomatic is important. But when they come to you with infertility in addition, there you have to do a balancing act and get the prolactin down enough to get her pregnant and then later on increase the antipsychotics or whatever. Even things like antihistaminics, opiates, benzodiazepine, metoclopramide, anything can raise prolactin levels. So we have to keep that in mind before we rush in and start our cabergoline. If it doesn't work, you have to do a surgery. Because and sometimes the prolactin levels are not very high, but there is too much tumor size. There also you have to do the surgery because there is a lot of theory behind it. I won't be going into it because it's a 20-minute talk. I would like to touch upon many topics before I go out. So then definitely if they don't respond to medical treatment, you have to send them to a neurosurgeon. Now, if the progesterone challenge test is negative, what then? You have to give your conjugated estrogen 2.5 milligram, that is 1.25 twice daily for 25 days, plus progesterone as medroxyprogesterone 10 milligram from day 16 through 28. If still she doesn't bleed, then you have to think of Asha Jain syndrome. Yes, you may get HSG reports showing filling defects, or you may not get it. I have seen patients with filling defects where I have done hysteroscopy and then put them on estrogen for 2-3 months, and then they started getting their periods. But I have also seen patients with very small looking uterus on HSG where there was no filling defects. And when I put the hysteroscope, I get just see bulge on the fundus. So that can be construed as an addition because I get so scared. I'm telling her that you will get periods after my hysteroscopy. I don't see anything on HSG and put a hysteroscope and I can't see any flimsy addition, whatever you try. What do you do? So here, there might be fundal addition, which the novice may not diagnose. So you have to just cut it with your Collins knife. Or there is a provision for making nicks on all the four walls with your Collins knife and also a little bit on the fundus. And that can be followed up with estrogen for 3 months and 60 to 80% will resume menstruation. What about the very severe additions? Those are difficult because first of all, your scope won't enter. And if it does enter, it will look like a uniconnuate uterus because 2/3 of the uterus is all addition is there in 2/3 of the instrument and in the uterus, and then you find it difficult to manage. But you have to understand that it's not a uniconnuate uterus; it is an addition, and you have to slowly cut through the addition. Therefore, an HSG is very important. In an HSG, you will find the filling defects on this side, whereas in a uniconnuate uterus, you will find a nice uniconnuate uterus on HSG. So whenever you have these cases, an HSG will help. That's one thing. And severe cases, maybe a lot of estrogen will be required. Genital COX should be done with check with a PCR or whatever, even, culturing for TB, whatever. So that's also important. Now, suppose you do get withdrawal bleeding, then it could be, the FSH level could be high, where there is ovarian failure. There you have to give menopause hormone therapy. Or if the FSH levels are low, then it could be hypothalamic failure, which has already been mentioned, or it could be pituitary failure. Now, let us go through the premature menopause that comes with secondary amenorrhea before 40 and FSH is high. You have to treat them, and the short-term thing is you have to, problem will be vasomotor symptoms, atrophic vaginitis, dyspareunia, or primary or secondary amenorrhea. And long-term, you will have bone or cardiovascular disease. I had a patient who delivered with me, and maybe 1 year later, she went into secondary amenorrhea, just 28 or 30 years old, and she had gone into high FSH. And I told her, and her mother died at the age of 50, cardiovascular disease. So and she also had secondary amenorrhea, and nobody must have diagnosed premature ovarian failure. And now her daughter has also got premature ovarian failure. And unless and until you substitute estrogen for these patients, they can have cardiovascular disease and they can have early death because of cardiovascular disease. So it's important to diagnose and continue to give estrogen and progesterone till the age of natural menopause. In patients who desire pregnancy, you have to give ART, donation, oocyte donation, or adoption, or something like that. Now, the patients who desire pregnancy with diminished ovarian reserve, with rank amenorrhea, or even very delayed periods, there are newer things like platelet-rich plasma, which is really cheap. You just concentrate the platelets from the patient's blood, and it can increase angiogenesis, cell migration, differentiation, proliferation, oxidation, and everything. And you can just collect it they give you a test tube with it, you spin it and take the platelet out of the top layer and inject it into the ovary through laparoscope or through the ultrasound. And it can be combined with stem cells taken from the iliac crest, and both are combinedly given into the ovary, and that can also help these primary ovarian failure patients who want to conceive. Now, the patients where you just want the symptoms to be mitigated, give either conjugated equine estrogen or micronized estradiol or valerate or whatever, 1 to 2 milligram per day or 0.625 per day, and give progesterone in the last 12 days. The progesterones which have less effect on the breast are breast cancer, at least, dihydrogesterone and micronized progesterone, but they are little expensive. If your patient is not that rich, you can even give medroxyprogesterone acetate in the last 10 days. Now, it's easy to give OC pills, no? Because it has estrogen and progesterone. What's the difference? OC pills contain ethinyl estradiol, where the estrogen doesn't get hydrolyzed fast. And one OC pill, even with 20 microgram, is equivalent to 4 tablets of conjugated estrogen, 0.625. So when you're giving 1.252 BD, the way they have asked us to give, it may be almost equal to a COC pill, but you have to avoid COC in patients who smoke or are obese or have migraines or have hypertension. Now, how long till the natural age of menopause, which is 46 in India? Side effects, you can have breast tenderness, you can have endometrial bleeding, which is good for the patient. I mean, they won't complain. Headaches may increase, changes in liver function, and rarely, even up to 78 weeks later, you can have inflamed pancreatitis. That's very strange. If there is breast tenderness or bleeding, you have to reduce the estrogen dose. If there is irritability or depression, don't say it's all because of your grandchildren or it's because you're worried about your husband that you're getting irritable. You have to reduce the progesterone dose. Understand that progesterone can cause irritability and depression. And water retention. The blouse is getting tighter, the churidar is getting tighter, things like that. You have to reduce the progesterone. And the patients who are getting fatigue, loss of libido, premature menopause, they do have loss of libido. Here you need testosterone implants, or if it's not available, simple, you give your tibolone. That is get converted to estrogen, androgen, and progesterone. So you get your feel-good factor also as far as sex is concerned. No bleeding, no effect on breast, and good effect on mood and libido. So that's maybe one up on estrogen progesterone therapy. It has been used for the treatment in the dose of 2.5 milligram per day for almost 20 years. So when you counsel a patient for hormone therapy, you have to say it does not restore reproductive function. You are not going to get with it. Menstruating is not a must, but preserving healthy estradiol level is, and that's why we are giving you the drug. Menstruation is just a side effect. We are giving it to you so that you won't die of heart attack, you won't die of brittle bones, you won't get fractures. That's important that you have to take it. But if you don't want children, please understand contraception is required in a woman who is wishing to avoid pregnancy, and treatment should be monitored with annual biennial hormone tests. What about functional hypothalamic amenorrhea? Dr. Lakshmi told us about that person, +2 woman who was studying, or the athlete I had a badminton champion. She had gone for Commonwealth Games also, but for 1 year, she didn't have periods. That was because they were exercising so much. And there are very finicky children who cannot eat at all. They rush off for their classes without eating, and they also go into amenorrhea. Here you have to give psychological support, sometimes estrogen replacement therapy. But these athletes, you have to either tell them to reduce their exercise or just not worry about amenorrhea because they have to achieve something. So but one thing is there. I had a patient long back who was a thin, 4-feeter, thin girl. She would not eat. She was looking tired. So the previous doctor had given estrogen progesterone replacement and she was bleeding on that. But they were not happy that she's only bleeding, and she's always tired. I said, bleeding and tiredness don't go well together. Something is wrong with you. And I sent her to the physician, and lo and behold, she had a brain tumor. So please don't fall into the pitfall that when you give estrogen replacement therapy and when they are getting periods, you just go on making them bleed only. You have to not overdiagnose hypothalamic amenorrhea all the time, that it is functional. You have to look for other causes. If there is, adrenals, Cushing's, all these things you have to look for in detail and not just falling into the pitfall of functional hypothalamic amenorrhea, which is stress-based. Because it happened to me, and then 2 years later, that patient died because of brain tumor. But at least a diagnosis had been made. But these things can happen. And now, finally, we all know the PPH woman. And she may go into amenorrhea. Please don't go into the pitfall of saying you are feeding your baby, so you may be having amenorrhea. She could be having Sheehan syndrome. So you have to test whether her ACTH is normal, thyroid is normal, maybe you have to check if the growth hormone is also normal. Another thing is, suppose they go into a PPH and they undergo a obstetric hysterectomy. That is also a scenario where you will not even think of a hormone replacement therapy because amenorrhea is there because of the hysterectomy. But you will miss out that she has to be given steroid because ACTH is not normal. You will miss out that she has got will require thyroid because you just expect that amenorrhea is there. So in a woman with a PPH where even obstetric hysterectomy is done, please remember Sheehan syndrome has to be kept in mind. I also know a relative patient of mine who has had a posterior pituitary going off. She had amenorrhea, but all her FSH levels were normal. But she used to have diabetes insipidus where she had to drink a lot of water and giving, desmopressin, nasal spray would stop her from drinking water. And throughout the 20 years after her delivery, she had to take desmopressin. But her FSH was normal. So that is the opposite. Sheehan syndrome is anterior pituitary and desmopressin replacement requiring for posterior pituitary damage. That is ADH, diabetes insipidus. So all this can happen with PPH. So an obstetrician cannot just think of amenorrhea. You have to think of a woman as a whole. When a woman comes to you with tiredness and everything, you have to check out all the hormones or at least refer her to an endocrinologist saying, I suspect Sheehan's even if she doesn't have a uterus. So that's important for all us to think about it. So I think, I don't know if I'm before time, I sort of finished telling you all that I thought is outside the curriculum. I have not touched upon everything that is routinely taught. And thank you for listening to me.
Thank you, ma'am, for that talk. I request the chairperson to please give their concluding remarks, or if they would like to add a few things.
Hello,
Yeah, please, Dr. Annie Sunil.
am I audible?
Yes, ma'am, you're audible, ma'am.
First of all, I thank Dr. Asha Jain for giving me the opportunity to chair this session, because most of you are unfamiliar to me. Only Shobana and Dr. Lashmi are familiar to me. Regarding Dr. Shobana, she's a well-known orator and well-known laparoscopic surgeon from Trichur, Kerala.
Thank you. Thank you,
Malayali, so no. So Shobana has given a very good, very vivid lecture on the various aspects of treatment of secondary amenorrhea, and which is that also depending upon the causes each and everyone specifically. And it is starting from the natural products up to the later of stem cell therapy and plasma platelet rich therapy and all those things. And also, I was also most of the time wondering how long I should treat this like hyperprolactinemia. And now only I know that we should treat it even 6 months after becoming this prolactin levels normal.
Most of the time we send them to endocrinologists. No, that's why we don't realize.
That's the thing. So thank you, Shobana, for such a nice talk. And thank you all for giving me the opportunity.
Thank you, ma'am, for your words.
Pradeep sir, would you like to add something?
Yeah, thank you, ma'am. Yeah, first of all, thank you on behalf of Mangalore Society for involving us. Yeah, it's a nice informative session on the management of. Can you hear me, ma'am?
Yes, yes.
Yeah,
Yes, sir.
It's an informative session on management of secondary amenorrhea. I think we all see every day a lot of cases of secondary amenorrhea in all age groups actually. I think, yeah, this makes us to make our practice little easy in treating the secondary amenorrhea cases in day-to-day practices. Once again, thank you on behalf of our society. Thank you once again.
Dr. Kutum Verma, would you like to add a few words, ma'am? I don't think, ma'am.
Every part of this has been covered, and I'm thankful Dr. Asha, especially Dr. Asha Jain, for making me part of this webinar. And she has covered all the things for the treatment of secondary amenorrhea. Nothing is untouched. Thank you, doctor.
Thank you, sir. Thank you.
Can I make a few one or
Yes,
two
I'm
comments?
so glad you have not
Yes,
gone off,
ma'am. Yes,
madam.
Shobana, I just wanted to say about these being overweight, PCOS girls and
Yes,
their diet. I know that they are not going to be happy But I
Yeah.
never give up, because I
Yeah.
think you leave them at this point with this kind of excessive weight. Like I said, every patient who comes to the clinic, even if the registrar postgraduate is bringing the patient to me, height, weight, and BMI have to be checked before they even enter my room. And they all know it, and even in the exam, as an examiner, I will ask. And if the BMI is even slightly higher, I think a dietary advice, not only to the girl, to the mother, to the father who brings every day evening a lot of mixture and samosa and
That is very
puffs
important.
to show his love. So I actually spend something like 20 minutes, and I have a nurse who will give this dietary advice. She will listen to me and she will just take them aside, and then we have
We all do that, madam. But initial thing is that they get angry. That is it.
yeah,
But
they
we have
do
to
get, but
yeah.
I think
But
yeah,
you have to take time.
yeah, one thing. The second thing is the growth hormone that you have written for Sheehan syndrome. Growth hormone is certainly not. See, the thing is, if she's got a Sheehan following a PPH, she's fully grown. Her epiphyse is all fused.
Madam, I just took it from books. I'm not vouching for it.
Growth hormone. I've managed a lot of Sheehan, and I happen to be married to an endocrinologist and therefore, just to say that we don't actually use growth hormone. Number one,
but the deficiency you have to check. Should we check
may
for
be
it?
there, but you can't do anything about it, and you can't administer growth hormone at this stage. Number one is the expense, and number two, she's not going to grow because her epiphyses are all closed. So we actually give them replacement of steroids, replacement of thyroxine, and of course the combination pill, whatever.
How often you have to give desmopressin, madam?
The desmopressin,
posterior pituitary.
Sheehan, we don't.
Sheehan is anterior pituitary, but what about the posterior? Have you seen cases?
We have. I mean, I have, and I know that they use it. But once it comes to that level, I generally send them over to the other side.
And the other side, yeah.
to my, yeah, right. Thank you. I just wanted to make these two comments.
Thank you for the comments.
Thanks.
So thanks a lot. Thanks a lot, my respected speakers, Lakshmi ma'am and Shobna ma'am. If you would stay on, if you have the time as experts, I would be really grateful. And somehow it's raining and there's a problem. Most of my panelists have not been able to join in. So requesting chairpersons, if you have this time, please stay on, because what our respected speakers have already spoken. We are just going to reiterate those things, how much we actually recall, how much we are going to apply. That is the only question that we are going to discuss in the panel. So may I have the CVs, please, so that we can just proceed with the panel. It will be rapid fire and we will finish on time at 7. Here also it has started raining and I'm working without electricity.
Yeah, we move
Next
to
slide.
the panel. Yeah, panel.
Yeah. Next slide, please.
I think it's Mr. Prajwal, right? I hope I got the name right. Yeah.
So our panelists are Dr. Ramesh Kumar R, who's the president of Hubli Society, Dr. Pradeep Dorle, secretary of Miraj Society. Dr. Pradeep has an emergency at home as could not join in, he informed previously. Dr. Annapurna Yalla ma'am, who's the past secretary of Rajamundry Society, who has kindly agreed to join this. Dr. Vasant Lakshmi Devi, president of Mandya Society. Dr. Sheila HL, secretary of Mandya Society. Dr. Sahana Nayak, secretary of Hubli Society. And Dr. Ekika Singh, president of Mau Obstetric Gynec Society. So welcome, respected panelists.
Please
you can stop sharing. Pranjal, please stop sharing. So we will now start the panel, requesting everyone to pitch in, and we start now. So hello. Namaste, ma'am. थैंक यू मैम, थैंक यू। सर्चलाइट चल रहा है, मैं आपको 2 मिनट बाद। हेलो,
Yeah, ma'am.
I'm sorry, there are so many calls coming in. So secondary amenorrhea is characterized by cessation of previous regular menses for 3 months or previously irregular menses for 6 months. That is the definition. And our speakers have actually told us what we are going to do. All this has been covered very clearly. So now we start with this first case. She is a 28-year-old lady. She's had irregular periods since adolescence, and her last menstrual period was 7 months ago. She has gained a lot of weight. She's hirsute, though she is going to the parlor regularly. There is acne. She's also under treatment of a skin doctor, and they are dermatologists. They have advised her, don't eat this, don't eat that. All that is on. On ultrasound, the ovaries are showing polycystic ovarian morphology, and she has an elevated LH-FSH ratio. Testosterone levels are high. Now, what could be the cause in this case? Yes, Dr. Annapurna ma'am.
Yeah, please, Annapurna ma'am.
Okay, this is good evening, madam. Thank you so much for having me here. Thank you, Sudhir Shah, also for calling me. So this is a clear-cut case of PCOS. We see like these days 3 to 4 people in at least in South India we see a lot of PCOS and PCOM also. Most of them have a scan done. They have the PCO morphology. So this is a clear-cut case of that. Most of them know it before coming to the hospital. Also, I have a PCO. I have PCO. They keep me. So for this lady, I just wanted to know whether she is married or not, and what are her concerns right now. Before
she's not married. She's not married.
Okay. So first of all, I would like to coming to management. Before management, she has done a LH FSH ratio and has high testosterone. I would like to do a TSH before. If the TSH is normal, then I would definitely ask her to see to reduce her weight. Lifestyle modification is the cornerstone for any treatment of PCOS because it is the lifelong.
Ma'am, may I interrupt for a minute?
Yes,
ma'am. What is the difference between a PCOM and a PCOS?
No, PCOM is just a part of PCOS. PCOM is morphology seen in ultrasound, wherein we have more than 12 follicles in one or both ovaries, and if the ovarian volume is more than 10 ml, then we call it as a PCOM, whereas PCOS is a spectrum wherein we either have hyperandrogenism, oligo or anovulation, and plus or minus PCO morphology on ultrasound. So,
ma'am, this patient is 28 years old.
Yes, ma'am.
Okay, supposing she were 18 years old.
Even if she were 18-year-old, the cornerstone of any PCOS is lifestyle management. Then comes the other kind of treatment. And because she has hirsutism and acne, before going ahead and before thinking she is only PCOS, I would like to do 17 alpha hydroxyprogesterone levels also to rule out the adult onset congenital adrenal hyperplasia syndrome. That is one thing which I wanted to add.
Yes, ma'am. But you know what? The reason I asked 18 years is because
in adolescence, you don't consider
in adolescence you do not label PCOS. So as you have said that so many patients will come, they will say we have PCO, we have PCO. But many a time it is not PCO. They are young ovaries. They had a couple of delayed periods. They got a scan done. And now that PCOS is riding on their heads.
Correct.
So I think we need to, this 28 years is fine. But in adolescence, we need to disillusion them that this cannot be PCOS. You just don't label yourself.
Yeah,
Here, this is clear cut. Yes. Here, it is clear cut. So you want her to lose weight?
Lose weight, have a good lifestyle.
she is doing PG in your department, right? So she doesn't have so much time to spare. She eats what she can. And, any kind of care for her is not very much possible. So now what are you going to do for her?
As always, even I am myself, I'm a PCO candidate, so in high stress environment, it is difficult to tell patients, but that we have to take time for ourselves. We have to steal time and get it done.
Yeah, so
Apart
I
from
think,
that,
that is the most important thing, that we need to tell patients that you have to take time out for yourself, but it's really tough. These IT kids, even the medical students, dentistry students, nobody has time. And if they have time, they want to go out and eat some junk. So, do you think you are going to give her hormonal treatment here?
Definitely yes, ma'am, because she has high testosterone levels and hirsutism and acne. Anti-androgens will do good for her.
So
maybe
what anti-androgen would you like to give? You want to give cyproterone acetate?
Yes, ma'am. I think cyproterone acetate would be suitable in this case because she has hirsutism and acne. These OCPs will
and
benefit her.
cyproterone acetate that will do regularize her.
Ma'am, for how long do you want to give cyproterone acetate? How many days?
Madam, in my practice, I usually give 3 to 6 months, and then in the meanwhile, I would ask her to reduce some weight, do some really intense weight reduction program, and then wait for some time, stop the OCPs, and then restart again if as per need. And for the terminal hair and all, she can go to a dermatologist and get it treated.
Yeah, so as Dr. Shobna ma'am had been telling us that you give her metformin,
yes,
or you give her dechiroinositol and myoinositol. So do you like to give that combination? And do you give that alone, or you give it with OCP?
Madam, for this girl, I think Maya inositol will do very good in correct dosages. Madam was insisting on the dosage because it's really costly, and the patients do take it just for 10 days, 15 days, and they think it is not working because they need over the night. They need the regularization of cycles, and then they can't. Most of them, the people who come to me, can't afford for a long run. But if they are able to take at least for 6 months and all, it will make a good. A good additive value to the hormonal milieu, I think. So,
Ma'am, my question here, Shobna ma'am, are you there? Shobna ma'am is not there. Lakshmi ma'am, are you there?
I'm here.
You know what?
I'm here.
Yeah, ma'am, I would like to ask you whether we give OC pill with metformin, with myoinositol, or we take them separately.
All right.
At the same time means not at the 3 months of this, 3 months of that. Is that how you want to give it, or you want to give it all together?
If the sugars are not elevated, I don't use metformin in PCOS at all. Because the weight reduction that you achieve with this is very marginal. We know that even with patients on with diabetes, that you might get about a 2 kilo weight loss in some, and you don't get more than that in many. So if I'm giving it for the regularization of menstruation, I think the OC pills will do the trick. I would add a metformin if she has any evidence of insulin resistance like acanthosis. So the clinical examination is extremely important. If she has acanthosis nigricans, if she has skin tags, if she has a very strong family history, and even if her sugars are marginally elevated, even 100 fasting sugar, I will give her metformin, because that will take care of a metabolic syndrome and prevent onset of diabetes later. And I'm doing that here for that purpose rather than the menstrual irregularity or whatever. And coming to and I don't use my Onostor. No, I don't use sorry, I think I'm an old timer, and I'm quite happy using the hormones for these. And when it comes to using anti-androgens, I know you didn't ask me that question, but I'm just itching to say it. I would score the hirsutism, and if it is forms and it falls under say less than 8, mild hirsutism, the combination pill will take care of the hirsutism. If the hirsutism is moderate,
Madam, but this
sorry, yes. Sorry, ma'am. Sorry, I think you want to say.
Madam,
something.
please go ahead. Sorry, this lady has high testosterone levels. That is the reason why I thought anti-androgens will do her good.
Again, depends on how high is high. We don't actually know the values, and if you can, in fact, if the hirsutism is more, I mean, if you feel that it requires particular attention, yes, and you can use ipratropium, and finasteride works very well for acne and hirsutism, especially if the hirsutism is moderate or even more than that. So I just wanted to, we can give cyproterol.
How long would you give it?
Yeah, the duration, ma'am.
For a minimum of 1 to 2 years till the hirsutism actually, it takes 4 to 6 months to show any effect. So there's no point in giving it for any length than that, because the entire hair cycle takes a long time. And so for any effect to manifest, it's going to take about 3 to 4 months. And you need to give it for a year. I have given it for 2, even 5 years for people with very severe acne and hirsutism, which was, bothering them. And then you can, of course, discontinue subsequently.
Ma'am, but if it's only for menstrual irregularities, how long would you want to give it, ma'am?
Sorry?
Ma'am, if it's only for irregular menses, how long would you want to give it without any hirsutism or acne? The duration,
if it is only irregular cycles, the combination, I would give combination pills, certainly for a period of 6 months to begin with, and I would stop and see. If she continues to have the same kind of irregularity, I switch to progesterone alone, given once in 2 months. Once in 60 days. I mean, I tell them, you wait for 50 days. If a period don't come, take it for 10 days or even a week. What I tell them is first to 10th of alternate months, and they manage their cycles. And of course, weight reduction and the other things along with that. Takes a long time to work it out. I have a lot of adolescents with irregular cycles, PCOS on ultrasound scan. I mean, whatever. I don't do other investigations unless they're really warranted. And I just keep them on progesterone alternate months after initial regularization, till, of course, they are ready to get married and have children. Yeah. None of them are going to go away from you in 2 months' time. They are stuck with you. You are stuck with them. And that is it. Yes.
Sure, ma'am.
Thank you, ma'am. Thank you. I think, this is going to be an extension to your lecture, because we are also eager to hear from you. Dr. Annapurna is there. Me and Sujya and all others are just listening in what you're going to say. So, ma'am, here's another patient. She is 24 years old. She is a competitive long-distance runner. LMP was 9 months ago. She has a BMI of 17 and has suffered a stress fracture. She's fatigued. Low LH and FSH, low estradiol. And the MRI of her brain is normal. So what are you going to do for this patient? This is hypothalamic amenorrhea. Dr. Annapurna, you and me are stuck. So you only have to answer.
No, we have Dr. Pradeep Ganiga sir with us. We can. He's the chairperson.
Pradeep sir is ready to answer.
Would he? You can ask him, ma'am, or Annapurna, ma'am, you can take the question.
Okay, ma'am. Again, this is really very, heart-melting situation. She's a young girl with a competitive runner, but having stress fractures with low BMI, it is really bad for her. So if she can take a break from her whatever training and all, she can take a break and have a good diet, a balanced diet, and train her muscles according to her schedule. And if she's definitely with the competitive she's a competitive long distance runner, she might be having a lot of psychological stress as well. So her stress could be managed with a psychologist, and she should have a holistic plan charted out for her. And we have to see other hormonal deficiencies also, since the MRI is of the brain is normal. Other hormones also should be seen, and she has to take a break from her career till she regains her normal health, I guess.
See, she has come to you after she got a stress fracture. So now she's not able to run at all. And she is even more stressed about it, you know.
I know.
So now, in that case, do you think you need the help of a psychiatrist or a counselor at least, or you want to do it yourself?
No, madam, we have to definitely have a rehabilitation psychologist and all for her to come back to her normal state. Her family should also be involved in the whole process. I think her family, her coach should be involved, and she should come back to her normal status, and her stress fractures should reduce. We have to see other causes for stress fractures, like if she's having any low vitamin D's or any other causes, brittle bones and all, hypoparathyroidism, those causes, and I think they should be addressed.
Yeah. So she needs an orthopedic consultation. She needs a psychologist consultation.
Yes.
And then we need to look after her amenorrhea. Yes, Lakshmi ma'am, would you like to add?
Yes.
Yes, ma'am.
These patients are very difficult to manage because they don't listen to you, and they are used to not eating, and there is definitely a psychiatric, psychological element to this whole process. It's not just the fact that she was a competitive runner. So you certainly need a psychiatric consultation. I agree with you. She needs a bone mineral density done, and to see why she had a stress fracture, how thin the bones are, and irrespective of whether, whatever else there is, that needs to be addressed. She needs to have a calcium phosphorus levels done, parathormone. I agree with Dr. Annapurna, and we need to address that and see whether she needs replacement of calcium, vitamin D, and bisphosphonate, whatever else that she requires at this point in time. And of course, amenorrhea is basically managed by, like everybody said, improving nutrition, lot of psychotherapy. Takes time, and it's really a difficult.
Ma'am, when FSH and LH are low, are we going to keep her on estrogen and progesterone? What are we actually going to give her?
Yes, we need to give her
cyclical estrogen and progesterone.
Absolutely. This is a
because see, bisphosphonates are not given as long as the patient has not attained menopause. You cannot give that. So in that case, how are we going to look after her bones?
No, if the fracture and the bone mineral density are so low, I think you need definitely calcium, vitamin D. At this point in time, the estrogen progesterone is actually the best treatment for the bone loss of bone mineral density is a combination with estrogen. Nothing equals that when it comes to bone loss, and therefore in a hypo, that is hypothalamic hypopituitarism, I think combination pill is absolutely, it's a must, and that's going to take care of all her other problems as well, amenorrhea and this. In addition, of course, to taking care of a bone.
These days, everybody is coming up with low dose, ultra low dose, ultra low dose.
No.
So, what dosage of the pill do you want here?
I want a proper dosage, what the ovary would normally secrete, because this is not postmenopausal hormone therapy. We are giving it to a young girl, and she needs a hormone at the dose that she actually. So you give the usual 20 microgram combination pill is absolutely fine.
Okay. So thank you, ma'am.
Ma'am,
because these are. Yes, Sujaya?
Ma'am, I have a question. When these patients are on OCP on long term, how frequently would you want to investigate them, and what lab test would you want to do? You want to check their
Put on your video, please.
What are you worried about? What are you worried about? It depends on that. If they are on this combination pill, I would definitely see them every year and look at their overall health. I mean, of course, initially I will see her much more often. I would see her probably every month or something. But if I'm giving her long-term OC pills, I mean, I'm not really, are you worried about thromboembolism or what side effect? If you're giving the 20 microgram OCP and she's doing well, I'm not going to do anything special for her apart from seeing her every year, because look at people who are on OC pills for contraception overseas. We may not see many of them here, but we do have friends and family and people overseas who take it for years on end. And if given at the proper dosage and if they don't have any risk factors for any complications, there's really no need to do any investigations on them periodically.
Okay. Ma'am, one question I wanted to ask.
Yes,
It's unrelated to this. It's what you said right now that you can give OC pills for years together. So if you give OC pills for years together, is it in any way related to the increased incidence of breast cancer, hormone sensitive breast cancers?
I think it's a very, very mild trade-off. Unless there is a genetic predisposition, giving just oral contraceptive for the purpose of contraception, or this has not been, even though it can be, when you list the risk factors for breast cancer, OCPs will certainly be listed. But practically speaking, because of probability of a breast cancer, I don't think we actually withhold oral contraceptives if it is indicated in anybody. Certainly not in somebody like that.
Ma'am, actually, in my own family, there is no history of breast cancer anywhere. And my sister, younger sister, had OCPs for 3 years. And she came up with a metastatic breast cancer, and in 18 months, we lost her. So that is why when I'm writing OCPs, it always comes to my head, is it safe? Because there's no family history of any kind. And it happened.
I agree. I think these kind of anecdotal things, especially when it happens in your family, have a lot of effect on your prescription pattern subsequently. But if you actually look at literature, just because of the fear of breast cancer, people don't withhold an oral contraceptive pill when it is indicated. And the currently available usual dose pill, I'm not even talking about the very or ultra low dose pill. The usual low dose pills are fairly safe. And if she is destined to, develop it, it's like a hormone therapy or menopausal hormone therapy. There are people who think it's how it is, the discussion can go on.
I know, I read that whole WHI trial and everything. So that's fine. Means I have never stopped writing HRT. But once it came in my family, I was a prescriber. So it's always there in my head that, did I do wrong? Should I have not written it? Anyways, so that's beside the point. We proceed with the case now. So this is the case of premature ovarian insufficiency. She is 35. She had regular periods until 18 months ago, and now she has become amenorrheic. Okay. Hot flashes, night sweats, vaginal dryness, elevated FSH, low estradiol. She is negative for FMR1 permutation, and she is positive for thyroid antibodies. So, what do you think is the diagnosis? And yes, please.
Has she completed her family, ma'am?
Yeah, she's completed her family, but means she's suddenly become amenorrheic. For 18 months back, she suddenly became amenorrheic. Dr. Annie, would you like to say something?
Madam, how is the endometrium like? Endometrium?
It's a thin endometrium. 3 mm endometrium.
Okay.
I think it is a case of premature. Can I speak? Am I audible?
Yes, ma'am, you're audible.
Yes,
I think it is a case of premature ovarian failure due to some autoimmune causes, because there is a thyroid, this thing is also there, and that may be the cause. So in these cases, we have to support this with the oral that's estrogen progesterone combinations. So till the age of menopause, till the natural age of menopause, that is what we have to do.
How are you going to deal with this autoimmune thing? For autoimmune thyroid, are you going to add something?
Yes, for the autoimmune thyroid, we have to treat the hypothyroidism also where that's associated with that thing. So this is a patient who has already completed the family. So we are more worried about the hormones, that is the ovarian hormones that are deficient. And because of this deficient ovarian hormones, it may lead to cardiovascular and then bone problems are there. So we have to protect the bone as well as the cardiovascular and as well as the central nervous system because of the
Means when I say completed family, means she has one child. She might still in the future want another child,
she
right?
wants one more
Because
child.
these days it is very common that to have one child, now that child is 14 years, now they want another child. So in that case, what would you suggest for her?
That's a question. So I think initially we had to protect this by her hormonal deficiency. That's the thing. By estrogens as well as the thyroid problem. Okay. So that has to be dealt with initially, and then only we can think of having another child or not. So for that, pardon?
No, please go ahead.
So for that, I think it is for the ovarian part. I think the conjugated estrogens, and then even now that they are suggesting micronized progesterone also. Along with estrogen, we can give some 10-day treatment of micronized progesterone so that her ovarian insufficiency can be dealt with. Then regarding that's infertility, secondary infertility. I think Madam can answer. Let me hear the Madam's, Lishmi Madam's opinion about this.
All right. The positive thyroid antibodies need not be treated if the thyroid function tests are normal. So she needs to have a thyroid free T4 and TSH. And if they are within normal limits, at this point in time, she doesn't require treatment, but she needs to be on follow-up. TFT, TSH, free T4 and TSH being done almost every year. She also needs to be evaluated for diabetes because these women tend to have polyglandular failure, which includes diabetes as well. If the sugars are become abnormal, they need to be continuously evaluated as in almost every year. Now, she is gone into a menopause as elevated FSH. She needs hormone therapy. There's no doubt about it. You could give the 17-beta estradiol come dydrogesterone or micronized progesterone combination, which is now considered to be the best and safest for the breast and to avoid other complications. If the patient cannot afford it, we are in India, therefore we still continue to give combination pill with the low dose, that is 20 micrograms or even less, and that will do the trick. And of course, since you are going to give her till the age of 50, if you start at 35, 15 years, when I say long-term oral contraceptive, we are talking about 3 years to 5 years. We are not talking about 15 years. When you talk about 15 years, I think you have to keep in mind the fact that you have to keep following her up and switch to the combination of menopausal hormone therapy whenever it is possible. But if they cannot afford it, I have personally kept patients on the commercially available combination pill because this is all that she can afford. If the woman wants another child, we have to counsel her and tell her that it's extremely difficult. There is a possibility you can, after giving this for a period of a year or two, people have stopped and tried inducing ovulation in the hope that there is a rebound response, but by and large, no. People even do a laparoscopy to see if there are some oocytes available and whether they can do assisted conception, but the results have never been very encouraging. That is what I would say.
So what I got from your answer was, ma'am, if there is one autoimmune disease, be aware that there could be more. You have to look for them. You have to manage them. Don't treat a report, treat the patient. So if her antibody is positive but thyroid is normal, don't treat it. And for fertility, a real counseling has to be done, and we are not to be afraid of long-term treatment. Now, this is a simple case, and it was very well answered, but just to remind ourselves, let's go through it. So she's a 32-year-old. She had regular periods till 12 months ago. Now she's become amenorrheic. She has galactorrhea, she has headache, she has visual disturbances as well. In her hormonal profile, everything is normal except elevated prolactin levels, which are around 300. MRI shows a 5 mm pituitary microadenoma. So what are you going to do? When do you think you want to send her for surgery? When do you think you're going to treat her on medicine? And how often are you going to follow her? These are the basic 3 questions.
Shall I answer, madam?
Yes,
So
ma'am.
she has a small microadenoma of the pituitary. So, first line would be medical management. And before that, we have to see if she has any defects, like any vision defects or any problems of the CNS. If she doesn't have any, we can go for medical management.
See, she has headaches and visual disturbances.
She does have headache and visual, but however, we have to map how much, what is the headache, what is the area of visual disturbances, and probably we can give a time of medical management till her prolactin level decreases, probably a month or so. Then if it doesn't decrease, her symptoms doesn't decrease, usually they do decrease, probably we can follow up with her MRI to see if any other tumors are there, new tumors are there. And then if she's not symptomatically relieved, probably we have to send her to a neurosurgeon.
Yeah, so you want to repeat her prolactin and MRI after 1 month?
If she's symptomatically subsided, madam, we need not do it. If she's having persistent symptoms, probably we need to check it again. And prolactin
Lakshmi
levels
ma'am, back to you.
Prolactin levels also, we need to see that when they have taken, is she on any other medication which will increase her prolactin levels. Here it is, we can see a cause for her increased prolactin levels. However, we have to keep that also in mind if she's on any other drugs which has effect on her.
One drug that is very notorious for increasing prolactin levels is Razor-D, Omase-D, these kind of things.
Yes.
Long-term use increases the prolactin levels very much. So, yes, Lakshmi ma'am?
Yeah, yes, I agree with the medication, the history of medications, but here she seems to have a microadenoma on an MRI. So even if she has, I mean, they have certainly prolactinemia inducing drug should be stopped. 5 millimeter microadenoma usually responds to medical therapy. Surgery for prolactinoma now is extremely rare. There was a time when we were operating on a whole lot, I mean, a lot of them, including, the transsphenoidal surgery, etc. But now microadenomas are all, and even small size macros are managed on cabergoline. It's a wonder drug. It really brings down the prolactin level. All their other symptoms will subside in no time. You need to check the prolactin levels only 3 months later. And if the symptoms persist or you really want to know, you can repeat an MRI. I doubt whether actually any of this is going to be required. Once she starts responding, the cabergoline should be continued for even 2 years, 3 years. Patients do very well on it, very minimal side effects. And when everything has come to normal, you could perhaps discontinue. People require it long term till the tumor totally subsides and disappears. Yeah.
Okay, so the earliest that we examine is after 3 months.
Yes.
And keep her on long-term follow-up at least for 3 years, at least. And then we have to keep her on follow-up that you need to come back.
Yes. Many of them, these tumors disappear and they do not come back. But of course, you just need to remember it and tell them to come and see you every year or something like that. Should be.
Okay. So when do you want her to have a repeat MRI, ma'am?
I actually may not do one. Or if the patient and everybody is very anxious, I won't do it earlier than 6 months. It's not going to disappear till before that. I mean, the 1 millimeter point.
Once it has disappeared.
We don't do it unless the patient becomes symptomatic. If she has galactoria, if she has a problem, we will do it. Otherwise, no.
Okay. We needed these clear guidelines for follow-up because galactoria keeps popping up. Even post-menopausal women, they'll just come up with suddenly some galactoria. So, very clear guidelines are needed here. So we come to the last case now. This is a 30-year-old. She had a DNC for miscarriage 18 months ago, and she has had no period since then. There is cyclical pelvic pain, but there is no bleeding. On ultrasound, you see, gaps in the lining. The lining is not very clear. It's thin and irregular. So now you decide to do a hysteroscopy and you find that there are intrauterine adhesions. Now this is just experts. So I'm asking you one thing. Do you think saline sonography would help in the diagnosis of adhesions before we proceed for hysteroscopy?
Madam, SIS usually helps us in knowing the extent of the disease, probably planning if we need a single setting, double setting, probably referring her to
so you
surgeon.
would do a saline sonography, right? Saline infusion sonography. That would, before a regular sonography and then a saline infusion sonography, and then you would proceed for a hysteroscopy.
You will receive additional information about the tubal patency also, considering she has plans of conceiving in future.
Okay. So now I'm asking you a basic, simple thing, that once your hysteroscopy is done, your adhesions are all cut away. What are you going to do for her? You're going to keep her on estrogen. In the olden days, it was said you put in a loop,
yes,
right? Now we don't get a loop at all. So do you think of putting in anything else, or what are your plans basically? How are you going to manage this case after?
If it is type 1 or type 2 adhesions, madam, no need to put any intrauterine device.
No, means you have cut away. They were dense adhesions. You cut them away. Now what are you going to do?
I personally do is put in a pediatric Foley's inside, give her high dose estrogens for 3 months and all, 3 months or
but
so.
But the Foley's will stay inside for 3 months.
No. For 7 days, I put Foley's, madam.
It comes out. It doesn't stay in.
I put in for 7 days, give high dose of estrogen, and then for 21 days, added with it last 10 days progesterone. Repeat it like that for 3 months. Then at the end of 3 months, do an ultrasound to see the endometrial thickness.
Here, she's having cyclic pelvic pain, but there is no bleeding. So her hormonal status should be normal, right? Her hormonal status should be normal. So are you going to check her hormonal status and then give her estrogen, progesterone? Yes.
Madam, here estrogen is being given to promote the endometrial growth, madam.
Yes.
Prevent the band.
Prevent the reformation.
Yeah, formation of bands. That's the logic for the estrogen.
Okay. So estrogen regardless of her regular menstruation. Now, this patient long term, are you going to search for endometriosis if she comes back to you with pelvic pain and everything?
Madam, here the cause, if it is DNC-induced adhesions or endometritis-induced adhesions, as indicated in this case.
She wasn't having any bleeding, right? She was having cyclic pain, but there was no bleeding. So is her long-term follow-up going to include our awareness for endometriosis?
Definitely.
Can I add something?
Yes, ma'am.
Yes,
ma'am. Please.
Because you are releasing the intrauterine adhesions, and after that you have asked whether we are going to put anything. Why can't we put a marina inside them, and that will help you in prevention of adhesions and as well as a hormonal status.
Ma'am, Mirena is progesterone.
Yes, progesterone. Okay.
Yes.
And anyway, prevention of adhesions, if we are putting that marina. Previously, we used to put Lippis loop inside after this adhesion release. Instead of that,
Lippis loop is fine.
That is innate. That definitely. But for some time, can we use that? That is my question.
So that question again has to be answered by our expert. Lakshmi ma'am, last question for you, please. We are all here
We're all
learning
depending
from
on
you.
you, ma'am. Yeah, no, we're all depending
No.
on you, Surgeon.
I'm not going to be the expert on this, most certainly. I have used intrauterine contraceptives in the past, and but I don't really know whether that is what helped the patient resume menstruation, and I patted myself on the back. Okay, that is what has basically happened. I have not used Mirena for this purpose. I don't see why not, as a matter of discussion with Dr. Annie. I mean, because Dr. Annie has brought it up. Yes, you are giving her oral estrogen, and then if you put in a progesterone pairing, it will just act like an estrogen, a little better than an oral estrogen, and the endometrial proliferation might continue. I don't have an answer to it because I have not used it, and I don't think there are any studies, and therefore nothing prevents us from trying it. If you have used copper bearing CDs, I don't see why you can't use a Mirena. If you're
Madam,
asking, sorry, yes, doctor.
can I counteract, because we put in Mirena to decrease the endometrial growth. Now we are want to improve the endometrium. So why do we put in a Mirena costly alternative?
No. The thing is, you put in a Mirena and give her estrogen definitely. If you don't give her, then it's a different matter. When you put in a Mirena for contraception, you're not going to give her. I don't know. I'm just talking aloud. There are no trials. And therefore, I cannot give you a final answer on that. Dr. Annie was thinking aloud, so I'm also thinking aloud. Now, if you do not.
Madam, that is because even hormone replacement therapy, we are suggesting Mirena along with estrogen. So why can't we do this in this patient? That is my decision.
Yeah, ma'am, there we are giving along with hormone therapy to prevent
along with
the,
estrogen, we are giving
no, we are giving that to prevent hyperplastic changes in the endometrium. It is not the same here, whereas here we want the
endometrium proliferate grow.
to grow. Yeah. So I don't know whether it will work. So I would, considering we've not had any trials, I would stay away
Ma'am,
from
I
it.
don't think it will work because here progesterone is coming in from day one.
Yes.
You first to estrogen and then you want progesterone. If you are giving it from day one, your endometrium is not going to grow. And here you want it to grow. So I don't think Mirena is the right choice here. But now
I agree with you. I mean, in the sense, I was also only thinking aloud. I have not used it. I have not read it anywhere.
No,
I mean, I was answering.
When OCPs are given, the earlier they are given, when combined pills are given, the endometrium doesn't grow, right? That is the way they work. The endometrium doesn't grow. And here what we want is that the endometrium should grow. And therefore, we have to give a high dose of estrogen and then add progesterone additionally.
Yes.
That is the science. So
combination pill will make the endometrium atrophic, whereas cyclical estrogen progesterone will make it go through the cyclical changes. I agree with you. Absolutely. Yes.
So now start with you, Dr. Annie. I just hope you've enjoyed it.
Yeah, really I enjoyed it. Because we have so many new things people are suggesting, and it's a good that's a good session for me also.
One take-home message.
Now that's the take-home message that what I have to say.
Yes, ma'am. Yes, ma'am.
So that means secondary amenorrhea is one of the commonest problems. And when there is an amenorrhea, we have to go into the detail. What is the cause of this amenorrhea, instead of just giving that's a progesterone withdrawal or estrogen progesterone withdrawal to give a bleeding. So we have to find out what is the cause, that is the thing, and then only treat it. That is one thing what I should do. And another thing is about the prolactinomas that we have to think, and this and how frequently we have to check it. And because in most of the cases, this hyperprolactinemia can be dealt with medical treatment, and so the treatment and then follow-up is only after 3 months with a prolactin checkup, and if it is not reverting, even then only we have to think of other modalities of treatment. So most of the cases will respond to this cabergoline or something, medical treatment. That is another point. And then what else?
Thank you, ma'am. Annapurna, ma'am, 1 point from you. And then we can come back to you, Dr. Annie, if you think of something. Dr. Annapurna, ma'am?
Thank you so much, madam. One point which I want to put it across everybody who's listening in the audience is to look for other autoimmune diseases. When one woman is having a premature ovarian failure, probably look for a Turner's mosaics because they have other specs. We have to check for that if we are suspecting autoimmune cause of premature ovarian failure. And thanks once again for having me here, Asha madam and Sudhir Shah.
Thank you. Lakshmi ma'am, there's one question in the audience. The audience has asked that there is a patient who was put on medroxyprogesterone for a year. Now, she has stopped that and she has secondary amenorrhea for 1 year now. After the last injection, it's already 15 months and she's still not getting her periods. What can be done?
This amenorrhea following medroxyprogesterone things is fairly common, even though we keep saying that they will resume menstruation immediately after. Takes about 3 to 4 months for a regular menstruation to set in. But if the amenorrhea continues for a whole year, it is certainly not, or at least let me say, most probably is not because of the medroxyprogesterone acetate. We need to evaluate her, do her hormonal profile, and decide on what the condition is. Is there a hypo that she has developed? Is there an ovarian failure she has developed? Whatever it is, it's not because, please do not think that it is because of the medroxyprogesterone. I think we
Dr.
need to
Renuka Devi Prabhakar has asked, this is Dr. Renuka Devi Prabhakar. She has asked this question. So, your answer is to evaluate. Don't think it is related to DMPA.
Yes.
Evaluate as a fresh case.
Absolutely. Yes. Yes.
Okay.
And
she has asked another question that when do you want to start metformin? Only after confirming insulin resistance, and how are you going to confirm insulin resistance?
No, I don't do insulin levels at all. It is an expensive investigation and an unnecessary investigation. If the sugars are, if she has got resistance clinically by way of acanthosis, skin tags, and if she has got even a marginally elevated fasting or postprandial sugar, I will start on insulin, not otherwise.
Okay. So I hope, Dr. Renuka, your questions are answered. And
my take-home message. Do you want
yes,
me to?
ma'am.
Yes. Okay. My take-home message is what I keep on insisting. History and physical examination on every patient. 80% of the time you have got a diagnosis. By the time you have asked her what led to it, what exactly did you have PPH, did you have this, do you have galactoria? You know, the usual stuff on history, drugs especially, and thorough physical examination. You know that if you just do an FSH, LH, prolactin or TSH, you can actually choose which one of these you want and you will have an answer. You will only have 5% of your patients who actually keep, make you think much more and wonder. And for them, you probably will need further evaluation and rack your brains. But otherwise, for the general practicing junior obstetricians, my message is proper history, clinical examination. That's it, including BMI.
When would you advise a genetic test on the patient?
Not unless she has a premature ovarian failure with the polyglandular, or even otherwise, premature ovarian failure, insufficiency, especially with polyglandular, definitely you do a genetic testing. Otherwise, it is really not required. No.
Okay. Sujya?
Oh, ma'am, I was going to repeat the same point. BMI is very important, as ma'am said, and also your basic battery of tests of FSH, LH, TSH, and prolactin will actually give you a probable diagnosis. Half your job is done with those basic investigations, so that you can get a probable diagnosis of the secondary amenorrhea before going into bigger investigations.
What I learned today is that microadenomas disappear. So,
definitely
that is something that I learned. And I'm really grateful for that, because patients will have a 3 mm, 2 mm reported and they are at you. Brain tumor ho gaya. We've got a brain tumor. So, that counseling takes up more time. And if you've heard it on authority, you have more strength to convince the patient. Yes, Sujya?
Yes, true, ma'am. Ma'am, before we end, I would personally like to thank Dr. Annapurna for joining in as a panelist at the end. And she's been the saving grace for today's panel discussion. So thank you so much, Dr. Annapurna. And it was a pleasure having Dr. Annie Suman with us, who's continued to stay on. And most importantly, Dr. Lakshmi ma'am, who's been the expert on today's panel. So thank you, one and all. It was a very informative panel. So I hope everyone who's watching has benefited from this. Last but not the least, requesting a nomination appeal for Dr. Asha Jain. She's standing for food, drug, and medico-surgical equipment. So kindly nominate ma'am from your societies. Thank you all.
Thank you.
Thank you so much. Lakshmi ma'am, it's been an honor and a pleasure having you here. I hope I can disturb you some other time as well.
Sure, anytime. Anytime.
Thank you, ma'am. Thank you so much.
Thank
you, Dr. Annie. Thank you, Dr. Annapurna. Thank you, Sujya. And thank you, Corona Remedies. Thank you, all delegates who have logged in and really made the effort worthwhile. We meet next week with late IUGR with a very expert speaker and questions that will help you remember what you learn. So thank you. Thank you so much. With this, we come to the end of the session. Requesting Pranjal, would you please end the session, please?